Okay, good morning, everyone, and welcome to the third final day of this Great New Horizons meeting. Welcome, everybody. We're beginning today with our theme of GIST research updates, and very pleased to have with us three distinguished doctors involved in GIST research and treatment. And I'd like to begin by introducing Dr. Kira Kelly. Dr. Kelly is a clinical investigator and medical oncologist at Memorial Sloan Kettering Cancer Center in New York City. She trained at University College Dublin and completed a visiting scholar fellowship at Sloan Kettering, doing research on the molecular landscape of GIST. In 2017, Dr. Kelly was awarded an American Society of Medical Oncology Young Investigator Award and Merit Award for her research. As a clinician, she specializes in the management of patients with GIST and sarcoma. So without further ado, I'd like to turn it over to Dr. Kelly. Thank you.
Thank you, everybody. Bear with me as I just share the screen. David, can you just confirm that you can see my slides properly?
No.
Not yet, no.
Okay, bear with me. Sorry.
There we go.
There you go. Okay, great. Is that coming up properly or just the...
It's not in...
It's on the speaker view.
Yeah, no problem. 1 second.
Great. Very good.
We can see the screen that has your reminders
yeah,
on
I'm just trying to get it to change.
Just letting you know which screen is showing.
Yeah. Sorry. I'm going to just stop it for a second. 1 second. Sorry. Sorry, having trouble with my mice. Can you just give me a few minutes? I'm sorry, I don't know if somebody else, I think I need to stop sharing it. I'm just finding it difficult to.
That's okay. Take a moment, and maybe while you're doing, I should say this is the first time in the history of Zoom meetings that anyone has ever had a technical problem. Just kidding. So we're all used to this by now. Yeah. After 2 years of pandemic. So while you're dealing with that, let me just introduce our other speakers for today.
Okay.
We're going to be hearing from Dr. Suzanne George. Dr. George is a medical oncologist at Dana-Farber Cancer Institute in Boston, focusing on sarcoma and GIST, with a particular interest in developmental therapeutics and clinical trials. Dr. George received her medical degree from the University of Massachusetts Medical School in Worcester and has been in practice for more than 20 years. She's a member of the multidisciplinary team at the Center for Sarcoma and Bone Oncology at Dana-Farber in Boston. And our final speaker is going to be Dr. Bruno Vincenzi. Dr. Vincenzi is the Associate Professor of Medical Oncology at the Campus Biomedico University in Rome, Italy, where he teaches immunology and medical oncology. He's actively involved in clinical and translational research, specializing in molecular diagnostics and markers of prognosis and response. He has a particular interest in cancer angiogenesis and in the development of angiogenic drugs. So this morning, we're going to hear from each of these doctors, and then we'll be having a general session to talk about unmet research needs. And now I'll turn it over again to Dr. Kira Kelly. Thank you.
Okay, thank you so much. I think my slides are correct now.
Yes. Yep.
Great.
Great.
So thank you very much to the organizers, Sarah and David, to everybody in the LifeArc group for inviting me to talk today. And I decided I'd focus my talk on immunotherapy and GIST. Here are my disclosures. And firstly, so the immune system has two types of response. There's an innate immune response and an adaptive immune response. In terms of the innate immune response, this is something that's time independent, not specific to any antigen, and consists of a variety of immune infiltrating cells. And then the adaptive immune response is time dependent. It's specific to a particular antigen and involves a memory function. And this is whereby we see a foreign object enters the body, an immune response is initiated, the adaptive immune response comes into play where B cells start producing antibodies, and they're retained within the body for each time thereafter that foreign particle enters the body, that reaction will kick in. So what do we know about the immune microenvironment in GIST? So we know that in terms of the tumor infiltrating lymphocytes, we see a high proportion of T cells and macrophages. With respect to the T cells, we see each type of T cell within the tumor microenvironment in GIST. So we see helper T cells that help essentially the CD8 cytotoxic T cells that I think of in terms of trying to eradicate the foreign particle from the body, and then the regulatory T cells, which are more immunosuppressive and are trying to dampen the immune response and create an equilibrium within the body. And in terms of the macrophages, when it's been looked at in preclinical models, we've seen that macrophages are present in both primary and metastatic GIST, but in a higher proportion of metastatic cases. And we see that there's a correlation between the macrophages and the CD8 Treg cells, which are immunosuppressive. So the phenotype of the macrophages are immunosuppressive M2 macrophages. And when we look at whether or not treatment plays a role in the presence of the macrophages or the immunosuppressive macrophages, really there hasn't been any evidence of an effect from treatment. So overall, the immune microenvironment in GIST is an immunosuppressive one. So what do we know about imatinib with respect to the immune response in GIST? So we know that imatinib potentiates anti-tumor T cell responses in GIST through inhibition of IDO. This is from work by Vinod Balachandran and Ron DiMatteo, published in 2012. And essentially, we saw that imatinib in preclinical mouse models, we saw that imatinib increased the cytotoxic CD8 T cells within the tumor and draining lymph nodes. It decreased T regulatory T cells and the immunosuppressive cells, and therefore shift the ratio of cytotoxic T cells to Treg cells in favor of a cytotoxic CD8 phenotype, which is seen in other cancers as well to be associated with a favorable outcome and prognosis. And how did it do this? It was shown to incorporate inhibition of IDO1. IDO1 is an intracellular enzyme that converts tryptophan to kynurenine, and kynurenine is an immunosuppressive to the microenvironment. And so it was also shown that imatinib mediated the reduction of IDO1 through its ability to block KIT signaling. So therefore, the tumor needed to be sensitive to imatinib. And they also showed synergy between imatinib and an immunotherapy agent, a CTLA4 inhibitor. So this is a lovely diagram of the potential IO strategies in GIST that are currently being looked at or have been looked at. And I took this from a nice review article that's been published this year. And we'll go through each of the potential avenues that have been looked at so far. So the first is cytokine-based therapy. And this paper is from 2012 also. It included 8 GIST patients that were treatment naive, and they were, the treatment that they received was PEG interferon alpha 2B and imatinib. And they saw a clinical benefit rate of 100%. All patients responded. And in fact, one patient had a complete pathological response in their tumor. And it was nice. This study was really great with respect to the correlative data that they showed, because they had samples pre and post treatment in this individual who had a great response. And they saw at baseline there was no interferon gamma expression on IHC. They also had controls from 3 cases that had been taken after imatinib therapy, and similarly, they did not express interferon gamma. And then after the combination with PEG interferon alpha 2b and imatinib, they saw expression of interferon gamma. And interferon gamma is a signal of a T helper 1 adaptive immunity and has been also associated with anti-tumor response. So this study was nice in that it showed that the GIST immune microenvironment can be manipulated. So the next is immune checkpoint blockade. And immune checkpoint inhibition has really become so important in the management of various cancer types, and has been FDA approved in a variety of cancers to date. Essentially, the immune system has various checkpoints that prevent the immune system going into causing excess inflammation within the body, such that trying to prevent the immune system targeting normal tissue and preventing an autoimmune disorder. So there are various checkpoints that can be blocked, which then release that inhibition on the immune system. And these include PD-1 and CTLA-4, for example. And so there's been 2 studies so far looking at nivolumab with or without ipilimumab in advanced GIST. Nivolumab is an anti-PD-1 therapy. Ipilimumab is an anti-CTLA-4 therapy. In the 2 studies, we really didn't see great response. There was one case in Arun Singh's study in the combination arm where we saw a complete response. In fact, the median progression-free survival for the combination arm was better than the single and monotherapy arm at around 3 months. And this was also seen in the second study, the Alliance, which had an expansion cohort in GIST. But we do see, and there have been published case reports where we do see good durable control from immune checkpoint blockade. And this is an example published by Seth Pollack and his group. And this was in a case of a wild-type GIST. And similarly, I've had that experience in my practice as well. So the next phase of research in this area has really been immune checkpoint blockade in combination with other therapies. So firstly, immune checkpoint blockade in combination with chemotherapy. And we have a study from the French group looking at metronomic cyclophosphamide with pembrolizumab. This study included around 10 patients with GIST. In the overall group, or in the GIST group alone, the 6-month progression-free survival rate was about 11%, and the median progression-free survival was 1.4. So not very good activity. And the great thing about this study was that the correlative work that they performed, again, they saw high levels of IDO1 expression in the immune cells following treatment in the GIST population. So 63% of immune cells, mainly macrophages, expressed IDO1. So suggesting that IDO1 again is potentially the IDO1 pathway is potentially a mechanism of resistance to immune checkpoint inhibition in GIST. And that led to a clinical trial of pembrolizumab in combination with epacadostat, which is an IDO1 inhibitor. This study, the results have not been reported, and I'm not aware of whether this study fully finished. Unfortunately, this combination was shown not to be effective in a large phase 3 study in melanoma, and the program pretty much shut down. So I'm not certain how many patients ultimately went on this study that we may be able to gain data from. The next is immune checkpoint inhibition in combination with tyrosine kinase inhibitors. And the tyrosine kinase inhibitors that we use, many of them also suppress VEGF. And VEGF is a mediator of tumor immune escape. It causes a defect in the functional maturation of dendritic cells and antigen-presenting cells from progenitors. And essentially, it's a key factor produced by solid tumors to inhibit their recognition and their destruction by the immune system. There's also another theory called the normalization hypothesis that essentially tyrosine kinase inhibitors that suppress VEGF ultimately are trying to improve and reduce angiogenesis and new vessel formation within the tumor. And by doing so, will actually somewhat improve blood flow to the tumor and ultimately oxygenation that may improve and produce an immune stimulatory microenvironment within the tumor. So many studies are ongoing and looking at this, and one that was published is that of a imatinib or a dasatinib in combination with ipilimumab, a CTLA4 blockade agent. And in this study, unfortunately, we didn't really see any responses, and the median PFS was about 2.8 months. Overall, it was felt that dasatinib probably wasn't the best choice of tyrosine kinase inhibitor, because from the earlier preclinical data that I showed, we need to see effective KIT inhibition in order to kind of stimulate that immune stimulatory response in GIST. The other trials that are ongoing in this area are many, and we look forward to seeing the results that they will provide, and in particular, the correlative data that they will share that will hopefully inform future design of IO studies in the future. So going back to our other potential IO strategies in GIST, the other more novel approaches, one is looking at an antibody drug conjugate therapy against KIT. And there was a compound LOP628 that was studied in preclinical solid tumors, showing good activity in GIST in both imatinib sensitive and refractory GIST samples. And interestingly, the antibody alone was not effective in inducing a response. It was only when it was conjugated with the chemotherapy agent that we saw a response. However, in the subsequent phase 1 study, 3 patients experienced a rapid hypersensitivity reaction to this therapy. And it was shown that mast cell degranulation was the reason for this. And this is because KIT is also a marker expressed on a variety of hematopoietic progenitor and stem cells as well. So I think until we can identify something that's truly specific only to the GIST tumor cell, or can direct it just to the tumor, this type of treatment will be challenging. So next we have a bispecific antibody therapy that is targeting somatostatin receptor 2 and also CD3. And this is an agonist of both of those, trying to stimulate the T cell infiltrate within the tumor and then stimulate the activity of the somatostatin receptor 2, which when joined by somatostatin, it results in an anti-proliferative activity by inhibition of the MAP kinase and PI3 kinase pathways. And there's a study, a phase 1 study of an agent looking at this that has already accrued fully. We're waiting for the results. And this was reasonable to utilize in GIST because we know that the expression of somatostatin receptor 2 is relatively high in GIST at about approximately 87%. And then that brings me to the final pathway that is a potential novel approach, and that is a CAR T cell therapy, whereby we genetically engineer T cells to recognize a cell surface marker on a GIST tumor cell, such as KIT. This has been shown to be effective in a preclinical GIST model and also in a hematological setting. But again, I worry that the fact that KIT is not just specific to the tumor itself and also expressed on other important cells within the body, this will be a challenging avenue to explore. So in summary, GIST has an immunosuppressive immune microenvironment. There are many ways to harness the immune landscape to potentially treat GIST. It's likely that we will need combination approaches with a view to converting the immunosuppressive tumor microenvironment towards an immune stimulated one. And there are several IO studies ongoing, and I welcome and look forward to seeing the data that they will share and bring to us in order to help us design future trials in the coming future. And with that, I'll leave this little picture and will welcome any questions that you may have.
Thank you very much, Dr. Kelly, for exploring the many avenues being looked at now in immuno-oncology. I think rather than move to questions right away, I think maybe we'll proceed with the other presentations. Would that be okay, Sarah? And then we'll take questions all together at the end? Okay, thanks very much. So thank you. And now we'll move on to Dr. Suzanne George, please.
I needed to unmute. Great. All right, hopefully you can see my slides okay. All right. Well, I just want to say thank you so much for the opportunity to come and speak today. Just by looking at the Zoom rooms, I see some familiar faces, and really do wish that we could be in person, and hope that that will happen again in the not so distant future. So I also recognize that there could be a fair bit of variability in the audience with regard to where you are in your journey with GIST. And so I have actually framed my comments more towards perhaps people that have had less experience with the disease. And so some of this may be repetitive for some of you, but I hope that it at least builds somewhat of a framework for people that maybe that have been in this longer, but also for some that are relatively new to the disease and to the entity. So what I'm talking about today, what I decided to talk about was I wanted to highlight some results from recent phase 1 trials in GIST and think about how that impacts future directions. And the reason that I wanted to do this is because in my clinical practice, I find that one of the most common things that people ask about are clinical trials. And when we start to talk about clinical trials, we talk about the different phases of clinical trials, phase 1, phase 2, phase 3. And I find that we spend a lot of time, either a lot of time or very little time talking about phase 1, because I think that phase 1 trials are people come to the table with different perceptions and understandings about them. And I wanted to take some time just to kind of give you my perspective about phase 1 trials and also how they've impacted GIST and how they likely will continue to do so. So what are phase 1 trials? Phase 1 trials are typically first in human trials. They may be the first time that a drug has actually been taken by a person. They have the goal of determining the optimal dose of the study of the drug. So if we're just starting to use a drug in person, we need a space in which to understand and learn what is the right dose to use. The trials also work to determine the side effects of the drug. Again, this is new. We're just starting to use these, and we want to understand what's the dose, how does it affect people. They also, however, we also will use a term called a phase 1b trial. A phase 1b trial will often be the first time that two drugs that have already been in practice are now being used together for the first time. And the goals are still the same, where we're defining the optimal dose of how you combine things, and we're learning what the side effects are. Phase 1 trials over the last several years have been increasingly novel in their design for two ways. One is that in contrast to historical phase 1 trials back in the day of early cancer therapeutic development, when we would just use drugs that were new that we thought would kill cells in the most general way, we would use them in cancer patients in the most general way. That isn't really what phase 1 trials are like now. The principles are the same. It's optimal dose determination and it's side effect and toxicity determination, but it's right from the beginning using rationally designed therapeutics, typically in a population that we think that they're most likely to be effective. So that although efficacy signals, meaning what percentage of people does this work in, is not necessarily what's called the primary endpoint or the first endpoint on the list of things we're trying to accomplish in a phase 1. It's a very important endpoint that's increasingly integrated into our phase 1 studies. Because of this, what you'll see in many phase 1 studies now that are built on this rational therapeutic strategy is that phase 1 studies will have very large expansion cohorts. And what that means is that once the optimal dose is determined, right within that phase 1, there may be an intentional group of people, cohort of people that are potentially eligible to further explore the side effects in a bigger way, but it's to also get a sense of signals of benefit. And that's what this phase 1 trial did with avapritinib. So avapritinib, which I know that you all talked about yesterday, is a very selective, potent tyrosine kinase inhibitor that was designed to be very active against a specific rare mutation in GIST called PDGF receptor alpha D842V that previously was refractory to currently approved therapies. Avapritinib also hits KIT exon 17, which is a common imatinib resistance mutation, but really the drug is exceedingly potent against this D842V mutation. And what this waterfall plot shows from the phase 1 study, again, this is a phase 1 study. I'm not sure if you're familiar, so I apologize if this is repetitive for some, but this is what we call a waterfall plot. And each bar on the waterfall plot, each bar on the waterfall plot represents an individual study participant and how much of the tumor burden reduced over time or increased. And for avapritinib, you can see that in this molecularly subset population, that nearly all patients enrolled had tumor reduction. The one patient with tumor increase actually didn't have a D842V mutation, they had a D842 other mutation. So this experience in this phase 1 was cumulatively the largest experience of patients with this subtype of disease. This benefit waterfall plot represents several different dose levels. So not all patients shown here actually received the same dose. Some of them received a lower dose in the escalation portion of the trial, again, because it was a phase 1. But this study also went on to expand various KIT mutant expansion cohorts and ended up enrolling close to 250 patients in a phase 1 to really get that sense of safety, toxicity risks, toxicity signals, and these efficacy signals. And together, this phase 1 trial led to the drug approval of avapritinib in this molecular subset of GIST. And I raise this because, again, I think phase 1s are built differently. They're not all the same, but in a molecularly rationally designed trial, one can learn a lot from a phase 1 trial. Let's see. This, oh my goodness, my slides are all out of order. Hold on. Here we go. Sorry about that. This slide summarizes a phase 1 trial that was happening at the same time that the avapritinib study was happening. And this was happening with ripretinib, which has since been approved and is known by the commercial name of Qinlock. Again, 3 major expansion cohorts. There are actually more, but I'm going to focus on these 3 expansion cohorts within the phase 1 trial of ripretinib. These are the waterfall plots. The top box is patients that had only received imatinib going into the study. And as you can see, some patients, it wasn't the right fit and the tumor grew. But for other patients, there was disease stabilization and shrinkage. This experience led to the phase 3 trial comparing ripretinib to sunitinib, which is accrued and expected to report out later this year. The middle panel is the waterfall plot for patients that have received at least 2 priors, so imatinib and sunitinib. And ripretinib was their 3rd line. Again, for some people, it wasn't the right fit. For others, it did show benefit. And the bottom panel are patients who received ripretinib in this study who had received at least 3 priors. So this is 4th line or beyond. And this is a space that there was previously no approved therapies. And as you can see from this phase 1 experience, there was an obvious signal of efficacy, of benefit. Again, many patients on the negative side of the waterfall, things going down. That led to a phase 3 trial, which ultimately led to the drug approval. So rational drug development, to me, especially starting from phase 1, is bringing the right drug that hits the right target to the right population. And we can see signals very early on. And I think that this is really improving the efficiencies of our drug development. I also think that in GIST, we have a great opportunity where, because we don't understand everything, but we have a good understanding of the foundational biology of the disease, that we can bring KIT inhibitors early on in drug development, treat patients early on to begin to identify those signals. Phase 1 studies can also include secondary questions that provide important information. And this was done very much in the ripretinib study, where they looked at intrapatient dose escalation, or they looked at patients staying on study after progression to see if this helped to benefit patients. And this paper's been published, which this is called a swimmer's plot, where each horizontal bar now represents an individual patient. And this summarizes the patient experience on drug, time on drug, either by the light bluish gray, when the patients were at 150 milligrams a day, or the gold bar, which is after they had been dose escalated to twice a day. And when taking this data together, the median progression-free survival, so the median time to progression, so growth of at least 30% or development of new lesions, on the low dose was about 5 months. And on the higher dose, looking at the same patients that had a dose increase, was again just under 5 months. So suggesting that there was similar benefit to disease control after dose escalation. We'll never know for sure if it was a dose escalation or if it's just remaining on the same drug. But it does raise an interesting question about benefit beyond progression with this particular agent. So all currently approved treatments for GIST are inhibitors of KIT. And I'm sure you've talked about this in the last couple of days. So imatinib first line, sunitinib second line, regorafenib third line, ripretinib fourth line, and avapritinib for the unique molecular subset of Peter-Jeff receptor alpha D842V mutant patient GIST. But I think really where we're going to start looking, and I think this builds on what Dr. Kelly says, is there a way to build on the benefits seen with KIT inhibitors by combining other drugs with them with unique mechanisms of action? This is a phase 1 study that was presented at ASCO this year, so the American Society of Clinical Oncology meeting this year. This was led by Cesar Serrano, who's at the Vall d'Hebron in Barcelona. And this is a unique study that combined imatinib as sort of the KIT inhibitor backbone with selinexor, which is a novel compound. It's a selective inhibitor of nuclear export. The thought is that it basically keeps important proteins in the cell that allows the cell to go on to cell death. And what you can see is that there were 3 dose levels, as would be standard for a phase 1, and patients were then followed. Important in this study is that everybody enrolled in this study had already had imatinib and progressed on it. So this is trying to salvage a treatment that the disease has already figured out how to get around. And I think what was interesting is that the authors reported that there were 2 patients, as is shown here in these yellow diamond shapes, who actually went on to have significant tumor shrinkage, and some patients who were able to who remained on study for more than 6 months, and 2 of those who are actually continuing at the time of publication. So it really raises an interest. I think this is hypothesis generating. I don't think it's as much of a signal as we saw in some of the earlier studies that I showed, but it certainly begins to wonder whether this may be an opportunity to learn more, and the authors are continuing to explore this. A similar study that's actually really very much a similar concept that's been very much put forth by Ping Chi, who's also at Memorial Sloan Kettering, has looked very much at combining something called a MEK inhibitor with a KIT inhibitor based on preclinical rationale that her group published several years ago. Just explaining this here, this is a xenograft, so a mouse model where GIST cells were implanted into the mouse, a tumor grew, they treated it with a variety of different things, and then mapped how it changed over time. The blue and the red line demonstrate with those agents. So vehicle is basically like a placebo. The MEK inhibitor is just the MEK inhibitor alone. The tumor kept getting bigger. This is an imatinib sensitive model. So the green line represents imatinib alone. And the tumors kind of stayed flat. It didn't really grow, but it didn't really shrink. And then when using it, using these two drugs in combination, the tumor actually began to shrink. So Dr. Chi and colleagues moved this into patients, and this was presented at ASCO 2020, so about a year and a half ago, virtual meeting. And this is a combination of imatinib plus the MEK inhibitor called binimetinib. And as you can see here, very impressive waterfall plot. Everything's going down, except for just a couple, except for just a couple of people. But what we know, and I think this is very exciting. It's really bringing proof of principle from the bench to the bedside. One of the things that, in my mind, makes this a little bit raises a question of how we have to continue to study this and learn how to apply it, is that all the patients enrolled on this study had never had prior Gleevec. And we know, or imatinib, sorry. And we know that imatinib is very effective as a single agent. So this certainly is encouraging, but needs further follow-up. And there's a soon to start phase 1 study with the combination of binimetinib and ripretinib in GIST. It's just got posted on clinicaltrials.gov on Monday. I just happened to discover it. So it'll be open. It looks like it'll be open both in Europe and in the several centers in the US. So I know I'm running out of time, but I'll just say briefly that to follow up on what Chiara was talking about antibody drug conjugates, I think this is a really novel opportunity for GIST. We just need to find the right protein target to carry the toxin into the cell. GPR20 is a unique protein that our group has recently published on that may be such a target. And there's an ongoing phase 1 trial currently halted for data analysis that is, hopefully we'll be able to explore that a bit more. I won't go into this too much for time. So in summary, I think phase 1 trials are tremendously important. They really focus on the rational translation of science from the bench to the bedside. And flexible study designs allow expansion cohorts when exploring safety and efficacy signals, particularly in rare tumor populations or subpopulations that have a very strong biologic rationale for the therapy being explored. Future trials, I think, are very much going to start focusing and continuing to focus on combinations of KIT inhibitors and other compounds, as well as novel KIT inhibitors to continue to build on the successes we've seen in GIST with KIT-directed therapies. Ultimately, this is not an ad to participate in phase 1 trials, but just really to help people understand what phase 1 trials are and the changes that they've been able to bring to the field. The ultimate decision to participate is certainly an individual choice. So thank you so much. I will stop my share, and thanks for your time.
Thank you very much, Dr. George. That was fascinating, and it's nice to see how today's talks are tying into the previous talks we've had in the meeting. And I'd like to encourage participants, if they have questions, to put them into the chat. We're actually right on time, perfectly on time. So we're going to move on to Dr. Vincenzi next, and then at 10 o'clock, we'll move into the unmet research needs discussion. And I believe that all of the doctors have been kind enough to agree to stay on through that session. So we can take questions for any of the doctors during that 10 o'clock session. So we'll carry on now. Thank you, Dr. Vincenzi. You'll be on next. Thank you.
So first of all, thank you for inviting me. Really, really, really happy to share my my research activities in my center, and happy to present this data after Dr. Kelly and Dr. George. Okay. Actually, I'm focusing on the research lines in my institution, but it is interesting because a couple of them have been very recently published. We have 2 current lines of clinical research. The first one is focused on the different doses of imatinib given as an adjuvant treatment in exon 9 mutated GIST. The second one is still focused on the adjuvant treatment with imatinib, and is focused on quite not very well studied side effect. It is about bone density and sarcopenia. And finally, we have a couple of research lines based on translational research. This focus on transcriptomic differences between GIST with different driver mutations, and some patient-derived cell lines with rare KIT mutations. The last two research lines are at a very early stage, and I cannot share anything of interest for you. At the opposite, I think that can be useful to share the data of the two clinical research lines. Why we are focusing on the exon 9 mutated GIST patients, because the exon 9 is quite rare, can characterize quite different GIST behavior in comparison with more common exon 11 mutated GIST. Exon 9 mutated GIST are more commonly observed in the small intestine. Also, the clinical behavior can be different with more common peritoneal diffusion rather than liver metastasis. And probably the most relevant thing is that the benefit associated with imatinib treatment, mostly in the adjuvant treatment but also in the metastatic setting, is less than the other mutation. In particular, if we compare the activity of imatinib with the exon 11 mutated GIST. We have data from a couple of different trials in the adjuvant setting. The first one is this trial published few years ago that support that the exon 9 mutated GIST can have later relapse after surgery, but the benefit associated with the treatment with imatinib with the standard dose of 400 milligrams is very, very low, or we can define also unrelevant. The same results have been demonstrated, have been published later in this trial, where no statistically significant difference in terms of relapse-free survival was observed in the specific population of the exon 9 mutated KIT GIST. Even if the numbers are very, very low, the authors concluded that exon 9 seems to have better outcome than GIST patients with exon 11, but no benefit from the adjuvant imatinib. These results can be associated with many different explanations. The more plausible is that probably patients with exon 9 mutations can benefit of higher dose of imatinib. These data were also demonstrated in metastatic setting by a quite old trial published as the META-GIST trial, where the authors, by combining two different phase 3 clinical trials, demonstrated that higher dose of imatinib seems to be more effective in exon 9 mutated GIST in comparison with the standard dose. On this basis, some physicians decided to offer higher dose of imatinib in exon 9 mutated GIST, even if scientific demonstration of clinical higher activity of higher doses are lacking. On the basis of this background, we decided to run a retrospective analysis that was published last month on the clinical cancer research. It was a big effort involving 23 specialist GIST centers in Europe across 8 different European countries. Most of the more expert centers were involved and contributed to the final data set. At the end of the story, we collected about 185 patients. Obviously, the retrospective nature of this analysis represented a big bias, but another big bias was represented by the physician selection biases, because obviously, according to the prognostic factor, physicians were more given higher dose of imatinib if the prognostic factor were more negative. So obviously we detected an imbalance between the two doses of imatinib in terms of prognostic factors. This was a big limitation and we were concerned, and for these reasons, we decided to use some statistical tools, the propensity score matching and inverse probability of treatment weighting, to mitigate the baseline differences and the associated biases. We decided to study 4 main survival outcomes: the relapse-free survival, obviously, in the intended dose population. It is very similar by definition to the intention to treat population. They modified relapse-free survival from the end of the adjuvant treatment to relapse, the imatinib failure-free survival, and obviously overall survival. This picture depicted the relapse-free survival curves, but in all the similar results were observed for all the different survival outcomes, and no significant benefit was observed in the higher dose imatinib treatment. At the opposite, some difference, even if not statistically significant, was observed in favor of the lower dose. This is quite strange to be explained, but probably could be related to some receptor modification that by pharmacokinetic point of view can be quite easy to be explained. And it is the same that in the metastatic setting can explain an higher activity of the higher dose. When correcting for baseline characteristic, no differences in survival outcomes between the two doses, with the high mitotic index and the non-gastric site that were consistently associated with worse outcomes, confirming what we already observed in previous studies. Obviously, this trial need to be further validated to be definitive, or probably an additional prospective trial should be run. But of course, it is limited by the extraordinary rarity of the entity. Remaining into the adjuvant setting, I wish to share with you this other data, not yet published, but actually under review, that is focused on the bone density and sarcopenia in GIST patients treated with imatinib in the adjuvant setting. The background is represented by the fact that imatinib targets c-KIT and PDGFR, of course, but also some other tyrosine kinase receptor, such as the macrophage colony stimulating factor. And on this basis, imatinib can influence muscle composition and also the bone health. So our hypothesis is that imatinib in the adjuvant setting may have a role on bone mineral density. These data were already explored in patients with chronic myeloid leukemia treated with imatinib, but also on muscle composition. And these two modifications, mostly on the muscle composition, can be associated with imatinib-related toxicity. We retrospectively selected patients treated in our center with high-risk GIST that completed 3 years of adjuvant treatment with imatinib. And we identified also a control group, age and gender matched, to compare the modification mostly in terms of bone density. Both muscle and bone density were evaluated on a CT scan at 6, 12, and 18 months. Considering the very strict inclusion criteria, at the end we identified only 14 patients and compared with the control groups. Obviously, as we can expect, men had a significantly higher bone mineral density comparison with women, and also in terms of smooth muscle index and lean bone mass, there was a difference in favor of men in comparison with women. It is interesting that during the treatment, bone mineral density showed a significant increase over time. This is absolutely the opposite with other treatments, such as other tyrosine kinase inhibitors and chemotherapy in other cancer conditions. And it is of interest that in patients with the basal level, with a lower basal level of BMD, BMD showed a significant increase over different time points, higher than the other population with a normal BMD. In association with these findings, we observed that the opposite. In patients with a lower BMI and a low MB, an higher rate of grade 3 adverse event was detected. This is not surprising, considering that imatinib can have a volume of distribution into the muscle and the lean bone mass. So it is not surprising that in patients with a lower BMI, we can expect an higher rate of higher toxicities. So in conclusion, we have analyzed for the first time the impact of imatinib on BMI and also in BMI and LMB, that discovering that BMD can be associated with an increase of BMD during treatment with imatinib, and that low BMI mostly is associated with a higher rate of grade 3 toxicities associated with imatinib in the adjuvant setting. And finally, this is something that we are exploring in the last months. We are trying to go into the mechanism of imatinib resistance in GIST treated with imatinib. We know that mechanisms of imatinib resistance are multiple, mostly associated with secondary KIT mutation, but very recent evidences support that also an overexpression of the cyclin D1 can have a role. On the basis of this hypothesis, we decided to explore also the role of CDK4 inhibitors that can be associated with a reduction of the combination of cyclin D1 and CDK4 and 6 complex that at the end of the story are associated with inhibition of the retinoblastoma phosphorylation pathway. So the hypothesis is that the GIST cells during the treatment with imatinib can have an increase of cyclin D1 expression that continuing imatinib treatment can be associated with an expansion of imatinib resistance tumor cells. Given concomitantly or sequentially after the development of resistance of some CDK4 inhibitors, the hypothesis is that we could reduce the spread of imatinib-resistant tumor cells and also the inhibition of tumor cells progression. So actually what we are trying to do in our lab is the exploration of CDK4 inhibitors, the three actually available, palbociclib, ribociclib, and abemaciclib, that are very well demonstrated that are inactive given as a single agent in GIST patient, according to the data published by the French group. But we are trying to explore in the cell lines who develop secondary resistances. So finally, I wish to deeply express my personal gratitude to the Italian Association of GIST patients for the continuous support in terms of research first, but also in terms of teaching activities in Italy. Thank you.
Thank you very much, Dr. Vincenzi. I think it's been great to see this. I think we've really seen this morning the diversity of approaches that are being taken in clinical research with regard to GIST therapy. It's really very exciting. We have a few minutes remaining before we move on to the unmet research needs. So I would encourage anyone who has questions in the audience to put them into the chat. And I know we have one already. It's from Martin Wetstein. And it's addressed to Dr. George, but I think I could probably generalize it to the other panel members as well in terms of their own research. So Martin Wetstein asks Dr. George, do we know anything about side effects from the combined treatments with selinexor and the MEK inhibitor? So maybe a more general way to put that question is, when we move to these combination treatments, what's the implication for side effects? So I'll turn that back to the panel, and maybe Dr. George, you'd like to lead that off?
Oh, sure. No, it's a really important question. Certainly when we use two drugs, then we are at risk for two sets of toxicities. And depending on how the drugs work together, if they have overlapping toxicities or side effects, then those side effects can be heightened when you use them together. And that sometimes builds into what dose we end up. Specifically with regard to the selinexor study, the primary toxicity that they had at that third dose level was nausea and vomiting, which is a real problem with selinexor as a single agent. That's something that can be a real challenge. So even though some of the benefit was seen at the highest dose combination, the recommended dose, if the combination moves forward, is actually one dose level down because of the GI toxicity.
Would any of the other panel members like to comment? I see Pete Knox has his hand up. Pete, do you have a question?
Yeah, a question. Let's let them comment if they want to first.
I can comment a little bit about the MEK inhibitor in combination with the imatinib study. I saw a number of patients on that trial, and a number of my own patients were on that trial. And it definitely, the addition of the MEK inhibitor to imatinib definitely exacerbates the side effects that we see with imatinib in general. So fluid retention, skin toxicity, rashes. But I can say that definitely with good management of those side effects in a supportive way, the side effects are definitely manageable in a long-term fashion. So in fact, in terms of the phase 1 study that was done, the recommended phase 2 dose actually was slightly higher than what we actually subsequently used to help with mitigating toxicity, side issues with toxicity. So definitely it takes a little bit of time to find that balance of what's going to work for the patient and from a side effect perspective, but it's definitely manageable.
Thank you. Pete,
so,
do you want to?
Yeah, so first off, great presentations, folks, on some very challenging topics. So kudos to all of you. I actually had a question for Dr. Kelly. I saw the mention of the cytokine therapy, particularly the PEG interferon and imatinib combo. And I agree that's interesting because it does show proof of concept about manipulation of the immune environment, but there were only 8 patients in the study. So do you know of any plans to either expand that study or any other cytokine-based therapy maybe you want to talk about that's ongoing? And obviously the other members of the panel can comment on that as well.
So that study was from 2012, and I'm sure there was hope to expand it at that time, but obviously nothing has come up since then. I'm not aware, I'm not involved in anything myself with respect to cytokine-based therapy, but I think there are a lot of novel agents out there and being developed that I would be surprised if we don't consider that, in the future. Maybe any of the other speakers can comment further as well.
No, I agree. I agree with what you said, Chiara. I'm not aware of cytokine-specific therapy happening in GIST right now.
Okay, thank you. We have a number of other questions coming in, and I'll just read one of them here from Saeed. Saeed says, I'm using Humira, a TNF inhibitor, as well as imatinib, 400 milligrams. Can Humira have a positive or negative effect on tumor growth? I'll toss that one out to the experts.
I think that answer is that we probably don't know. We have never studied the two of them together. So the purpose of it's a challenging one, because I guess the Humira is there to help treat an autoimmune condition, potentially something like inflammatory bowel disease, perhaps, whereby you're trying to dampen the immune response within the body. So, but whether it would have a negative or positive effect, truly, we don't know unless we studied it further, I feel.
Yes, I agree. It's really hard. And I think that for an individual, it's always a balance of what's the right mix of treatments for what somebody needs as a human. You know, you have to do what's right for all of the health issues that you have.
I will comment as well, you know, when we're using these immunotherapy agents, I will preface and say, obviously, immunotherapy is investigational in GIST, and I guess what my presentation was really trying to like hypothesis generating and just showing what research is ongoing and how we're thinking. But like Suzanne said, you have to be very mindful of everything that a patient is experiencing and the conditions that they have. But I will say, when we use immunotherapy, I also treat a different type of cancer, Merkel cell, where immunotherapy is the predominant treatment for that disease. And there are patients who also have autoimmune conditions that are on potentially steroids or other immunosuppressant therapy. And just because they have that history in trials, they're often excluded from involvement. But we are, with greater knowledge of using these immunotherapy agents in cancer, we are adding to that body of literature, and there are patients who have those conditions where we are treating with immunotherapy, but you do so in a very kind of controlled fashion, making sure the other person, the other doctors that are helping to treat the autoimmune disease are on board, and you work together managing the patient in that way. So there's, you know, it's definitely a balance, as Suzanne explained.
I think that probably the daily clinical experience learned us that the vast majority of patients receive a lot of concomitant medications. The anti-TNF is one of them. So probably the main concern is not related to the efficacy of the treatment, rather than the potential overlapping toxicities of the drugs. But it is just an example, because it is true for many other different concomitant drugs, not only the immunoactives.
Thank you. So I wanted to turn now to a question that's actually coming in from more than one participant. And this is with regard to the effect of imatinib on bone health. And so the question is, since people are now taking imatinib over many years, what does a long-term imatinib patient need to be concerned about in terms of managing bone health? I'll put that out to all of the doctors.
Yeah, well, what we observed is that just after 1 year, mostly in patients with low bone mineral density at the beginning, the baseline, we may observe an increase of bone density. This is something that was already demonstrated in CML, exactly at the same time point.
Anyone else want to comment on that?
Can I ask, Bruno, did you look at, I mean, it may have been very difficult to do so, but like look at maybe skeletal events or anything within the populations?
No. But these patients were all adjuvant patients in the adjuvant setting. So we did not observe any skeletal event in this very small population. But we plan to give a look to in the metastatic setting, obviously because the duration of imatinib treatment is longer. But it is something of interest. Actually, we are exploring the circulating biomarkers of bone health, such as CTX, NTX, and so on. So it is a nice area of investigation, honestly. It is definitively unexpected.
Yeah, no, and I'd love to know what happens for patients who stop imatinib and what happens to their bone health in that setting. It's fascinating.
Yeah.
Thanks. And there are a number of other questions coming up with regard to bone health. So I think we can look at this as an emerging topic of interest to both the patients and the doctors. In view of the time, I'm going to move on to one final question from the audience, and then we'll move into the research needs questions. So Catherine asks about, and this is a question that I think I've seen come up quite frequently. What about management of nausea, and in particular PPIs, drugs like Nexium, which I know are very widely prescribed along with other drugs. So I was told, Catherine asks, I was told that PPIs like Nexium can affect the efficacy of Gleevec. And I wondered if any of the doctors could comment on the use of PPIs along with Gleevec.
You know, I think that there's a lot of data that's emerged that long-term acid suppression, independent of being on Gleevec or having GIST, is not great for people if it can be avoided. It's actually another issue related to bone health and absorption and things like that. So we try to see if people can tolerate not being on PPIs for many reasons. But some people, it's just what they tolerate. It's what they need in order to be on their drug. And so if people need to be on a PPI or, you know, some chronic acid suppression in order to tolerate either their prior surgery or the drug, then some people need to be on them. But generally, we're trying to help people to not need them if possible. Not so much because I'm worried about the interaction with Gleevec, or imatinib, not so much because I'm worried about imatinib interaction, but more because I think it's more around sort of long-term side effects of PPI use. I don't know how others practice, but.
I agree on that, totally. It is the same attitude we try to follow to exclude PPI as a standard chronic treatment in our patient on the basis of the data published on other TKIs, but probably the effect is definitely overlapping also for imatinib.
Yeah. I think that's a good point. I mean, there's much clearer data around drugs like pazopanib, for example, where the gastric pH makes a much bigger difference on absorption. I don't think that data exists to the same extent with imatinib, but some other drugs, it makes a really big difference on how well the drug is absorbed. I think for some people, as you all know, you're living with this disease, the nausea can be really challenging. It's low level and chronic. I just wouldn't underestimate the importance of eating, about taking imatinib on a full stomach. I think it's probably the best way to manage imatinib associated nausea. But if despite taking the drug on a full stomach, there's still chronic nausea present, sometimes we have people take anti-nausea medicine chronically 30 minutes before they take their imatinib if needed.
Thank you very much. Those are some important practical questions and advice. Much appreciated. So we're now going to move on. There are still a few more questions in the chat, but we can catch up with those later, maybe after the meeting. So let me move on now to our next final part of this morning's, the first session this morning, and that's the topic of how do we address unmet research needs. And I'd like to begin that by asking the following question, which each and all of the panel members might like to respond to in terms of where we can go next. So we all know that GIST research relies on a lot of specialized tools. We've heard about some of them during the meeting, specific drugs, specific inhibitors, antibodies, cell lines, animal models, other assays. So suppose I had a magic wand and I could grant each of you one new research tool, one new tool to use in your research. What would you ask for? What do you most need? So I'll toss that question out to each of the panel members, please. And you can go in order. I'll start with Dr. Kelly.
So thank you, David. This is not an easy question to answer. I don't think there's just one thing. I think
I've only got one magic wand.
Well, I'm gonna suggest something that's not actually in your list, and it's collaboration. I think that's the key to success in research, particularly with a rare tumor. And I think all the studies that we've highlighted, or many that Suzanne and Bruno have highlighted, happen through collaboration. And I think that is the key. An international database of GIST patients that we could utilize would be ideal. And maybe that's something to strive for.
Yes, and that's certainly something that LifeRaft Group is very involved in. Great. Turn to Dr. George.
Yeah, actually, my thoughts were very similar to Dr. Kelly's. I think if you could do one thing, or your magic wand could do one thing, it would be to break down the regulatory barriers internationally, to make it easier to collaborate between countries. That's sometimes such a tricky. Every country has their own regulatory rules that can really get in the way of a lot of practical aspects of clinical trial execution, for example. And while you're doing that, if you could create a model that was truly, completely reflective of the human GIST experience, that would be great too.
Yeah, I was wondering about that. And an animal model that was truly, yeah. I think that's an important question. Maybe I'd like to comment on the relevance of these tumor xenograft models, for example. I mean, how well do they really reflect or model the human patient experience? I think it's very important.
I actually think a lot of them do. The thing about GIST is, because we really can focus on the specific kit, we have a good understanding of primary oncogenic drivers, like what's driving the tumor. We have a good understanding of resistance mechanisms, at least in the kit associated, secondary resistance mutations. These models grow well in mice. I think we have a good handle on that. But at the end of the day, the way a drug works in a person and how the escape mechanisms happen in the human system, it's very difficult to model that in an animal model. So I think the models I do think that they give us great hypotheses, but at the end of the day, it's really what happens in people.
Thank you. And I'll turn to Dr. Vincenzi. By the way, I have a magic wand, but to overcome international barriers would require a truly miraculous magical wand. But I'll turn to Dr. Vincenzi now.
Well, it is very hard to add something, because both Dr. Kelly and Dr. George focus on exactly what I think it is the major barrier. So we should try to promote collaboration, but make easier also the regulatory processes. Actually, in my country is definitely a big issue, and I'm really concerned that in the next years, the situation will be even worse. So probably it will become harder and harder to run, just to make an example, the collaboration between these 23 centers for receiving few data about the exon 9 mutated GIST patient in the adjuvant setting was quite difficult, but in a period of time in which we had got relatively few barriers. Actually, the situation is becoming extremely dangerous for making spontaneous researches. So I think this is something that probably also the advocacy groups should try to help, also to make more homogeneous the situation across the world.
Yes, well, I think for that's a theme that's run through the whole meeting for sure. Great. Okay, thank you. Actually, you've all rather cheated, I think, because you've seen my second question and you've already been answering it in a sense, but I'll move on to my second question. So most GIST research is taking place in the US or in Europe, but there are patient advocacy groups in smaller countries, such as our own group in Canada or New Zealand or Australia. And we have developing countries like Chile and Kenya that are represented here, and they also want to support and encourage local GIST research. So what would you recommend as the best way for groups in smaller countries or that are less involved in, that are not at the forefront of GIST research? What would you recommend as a good way for us to promote GIST research in our own countries? Maybe let's go in reverse order and we'll start with Dr. Vincenzi.
Well, I think this could be, well, it is the story of the rare diseases, the rare tumors. The advocacy groups from even small countries contributed a lot in the research. So this could be replicated also for the GIST community. I think that by collaboration between also the advocacy groups should be promoted exactly in the same way, at the same level of the collaboration between physician collaborative groups involving physicians. So obviously also the activity of advocacy groups in helping physicians by achieving resources, financial resources, could be very helpful, and it could be a useful tool for helping also small countries and coming into the bigger collaborative group.
Thank you. And the other doctors would like to comment?
Yeah, you know, I think understanding what the barriers are in individual environments and where the champions are in individual environments can help perhaps see what's possible in those spaces. So what do I mean by that? I mean, it might not be possible in some of the countries that you listed to do a phase 1 study with biopsies at every 6 weeks and blood draws at every, 8 hours and processing the samples and having them shipped all over everywhere. Maybe it is possible. I don't know. So I think understanding what's possible, there are always questions that can be asked. And I think that's questions that can be answered. We just need to think about what the environment is and ask the questions that work in that space with the people that are interested in being involved and the champions to see it through.
Great. And Dr. Kelly, any comments?
Yeah, like just to echo the sentiments of Dr. George and Vincenzi. Again, I think even before the research question, partnership with centers, like if you could partner a champion from a smaller country with a sarcoma center in a more established country, and allow that then to develop both firstly from a clinical perspective and helping to answer complex clinical questions and being a support there for information and a resource. And then with that, hopefully that would foster, development of research as well. So I think that's something that I would suggest might be meaningful to consider.
Thank you. We have a few more minutes left, so I'm going to read you a question that's come in from Deb. In a way, it anticipates our next session, but I think we can jump ahead to it. Deb asks, with regard to SDH deficient GIST, what do the research scientists here today need to move research forward in the area of SDH deficient GIST? Could I ask any of you to jump in on that question?
I actually think that, I'm going to let the others, I'm just going to say briefly, I actually think that this is another great opportunity for collaboration and awareness. There's actually a fair bit going on in SDH deficient GIST right now. And I think that there are, firstly, just the fact that it's spinning off is important, that it's being looked at separately, that the biology is being looked at separately. But this is because it's a rare subtype, we need to find ways to stay connected so that patients are aware when there are trials available. And we need to make the connection between the trials and the patient community. I just have to get a quick urgent page. I'll be back. I'll let the others respond.
I know, let's say from a preclinical scenario, when we're trying to develop like good rationale for SDH deficient GIST, I think that seems to be a very challenging area. We don't have great cell lines within SDH deficient GIST. So I think that's something that hopefully in time and through collaboration, we may be able to, develop, I hope.
I think that GIST patients are following the same destiny of more common diseases such as lung cancer, colorectal cancer. We are splitting into different molecular subsets, and also the old wild type GISTs are becoming more clear, the molecular pathway. But Chara introduced this aspect, the collaboration in a so rare medical condition is so crucial. I think that in the field of sarcomas, I can remember, for instance, the inflammatory myofibroblastic tumors. Actually, we have all the ALK inhibitors in this area for an extraordinary rare disease. Probably this should be replicated also for the SDH deficient GIST. Very, very rare, but we can do something altogether.
Thank you very much. I think we've already seen from the pages going off in the background that I've always said that medical oncologists are just about the busiest human beings on the planet, and we very much really appreciate your taking the time to give us all this knowledge this morning. I'm just going to read a comment that's come in, and I think we can all echo it. A patient who writes, "As a newly diagnosed and treated GIST patient and a physician, in fact, I'm overwhelmed by this presentation and the information made available to this patient group. All of you are amazing and very appreciated." I think we can all very much echo that. You folks are all amazing. It's been a great morning. I think if it's okay with Sarah, that we'll just end the session at that point and take maybe a slightly longer break before we come back on SDH deficient. Would that be okay, Sarah? Am I allowed to do that on the spot?
Sure.